The Australian healthcare system, and often you and me as consumers, spend a fortune on testing to see whether we have heart disease or at risk of a heart attack. One such test is called a coronary calcium score. It involves a CT scan of the heart, looking at how much calcium is built up in the coronary arteries. We've covered this before in the health report, questioning the value of a coronary calcium score. Well, now the Baker Heart and Diabetes Institute is starting a study in otherwise healthy people with a close family history of heart disease at a relatively young age. The person leading the study is Tom Marwick, who's the Baker Institute's director, and he's in our Melbourne studio. Welcome to the health report, Tom.
Hi, Norman. Thanks for the invitation.
So what's the question you're trying to answer here?
Well, it really arises from clinical interaction. I quite often see people who have a family history of heart disease. They may come in to say that their father died at the age of 58 and they're in their early 50s, and what should they do? And obviously in that situation you need to ask the patient carefully about symptoms, and sometimes they actually have symptoms that they haven't admitted to anybody previously, and then you treat that on its own merits. But many individuals are truly asymptomatic, and then you calculate their risk using a risk calculator. And
so just to explain that brings together your family history, whether you smoke, your blood pressure, your cholesterol levels and various other factors, and then you get a score, your percentage chance of a heart attack in the next 5 or 10 years.
Yeah, that's right. So, and that's what you would do really for a routine sort of over the age of 40 check. And then, you can identify some people at very low risk and a few people at very high risk. And then there's a group in between at intermediate risk where you're really trying to balance up the fact that they haven't got a very high risk of disease, but they have a family history. And unfortunately, the risk calculators don't take family history into account. So it's a frequent problem, and it's a source of frustration to all, I think.
And that's where you're testing this ground of the coronary calcium score.
Yeah. So our plan was to take these people with a family history, do a coronary calcium score on them. If they had a score of between 0 and 400, then to randomize them to a study with a statin or none. People over the score of 400, clearly have coronary disease, and
this is like a cutoff. You're talking about the 400.
Yeah, it's the score is derived from the total extent of calcium in the vasculature, and it's kind of a reflection of the amount of atherosclerosis in the arteries. And a score of 400 is a meaningful score, prognostically, and warrants some further evaluation, perhaps a stress test. Very commonly, that's negative. But those individuals, I think you could make a pretty strong argument to treat them with a statin. The individuals with a calcium score of 0 have got a very low risk. It's a very reassuring finding. And the people in the middle, it's very difficult to know what to do with them.
Look, I thought, we first covered this years ago when it first came on the market, and before the studies were done, and it was thought it was pretty useless that you could have a 0 coronary calcium score and drop down dead of a heart attack the next day. But I think the CT scans have improved since then. But nowadays you've got what's called CT coronary angiograms, which are fairly benign tests. Check your coronary arteries. If they're as clean as a whistle, off you go. And if it finds something, then you can go on to, say, having a stress echo or something like that. Is there much point with a CT coronary angio available to you? Why would you bother doing a coronary calcium?
Well, I think they're giving different signals. I think when you do the CT coronary angiogram, you're looking for the presence of obstructive disease, and when you're doing,
isn't that what you're looking for in the coronary calcium score too?
No, absolutely not. No, you're looking for evidence of atherosclerotic plaque in the coronary arteries. So if you find a coronary calcium score of 0, those individuals are extremely unlikely to have plaque in the coronaries. So I think one of them is
probably
really...
just the missing bit here for the audience is that calcium lands there and sticks from the blood supply, and that's as a kind of marker of the plaque, of the cholesterol plaque.
Yeah, absolutely. So it's a disease marker rather than a risk factor. Absolutely. So this isn't something that's bad about calcium that comes to sit in your coronary arteries and cause mischief. It's kind of a bystander in the disease process, but it's a marker of the disease. Yeah.
So if you like, so what have you found so far? I realise the trial's just getting going.
Yeah, so we've been going actually for a couple years, a multi-centre study really in all of the capital cities. And we obviously have follow-up to do for several years more, but we do have the baseline data. And it's very interesting that these folk who are at intermediate risk with a family history of premature disease, I would have thought that those individuals will be very likely to have evidence of coronary disease. In fact, 50% of them have had a score of 0.
50%?
Yeah, very reassuring result.
Is that because
And not one that I
they're scared as hell and they're living pristine lives?
Well, I don't know. I mean, I suppose there is a significant genetic component to this disease, and I suppose their lives aren't that pristine because they're at intermediate risk, so they've got, an elevated cholesterol, or they smoke, or have high blood pressure. So no, I don't think so. I think the message from this is that there is actually a different signal from the coronary calcium score than we're getting from the coronary risk evaluation. I think maybe it's a reflection of the protective process that you can expose two people to the same levels of risk factors. So one of them develops coronary disease and the other does not.
And time will tell whether intervening makes a difference.
Oh, absolutely. Yes, I think, as you said in the introduction, I think we've jumped the gun on this, and people are being managed as though we've proven this, but in fact we haven't. We have shown that the presence of calcium is a marker of disease, and we've shown that it's a marker of prognosis, but we have not shown that by intervening that we can change the outcome. And this trial will show that for the first time.
And you're looking for people with first or second degree relatives with early premature heart disease. How do they participate in the trial if they want to?
Yes, so all they need to do is to go to the Baker Institute website and look under patients, and there's a list of trials there, and the trial is called CAUGHT, CAD, CAUGHT, for coronary artery disease. And
all you need to do is have a CT scan of the heart. Tom, thank you very much for joining us.
My pleasure, thank you.
Tom Marwick is Director of the Baker Heart and Diabetes Institute in Melbourne. Some of the commonest painkillers bought across the counter are called non-steroidal anti-inflammatory drugs, or NSAIDs. Medications like ibuprofen or naproxen, the trade names are Nurofen or naproxen. There's been a suspicion that in some people they may increase the risk of a heart attack, particularly a newer, supposedly lower risk NSAID called Celebrex. Well, now a huge trial has been published comparing these three NSAIDs and their heart risks. And one of the authors was Professor Neville Yeomans of Western Sydney University and the Austin Hospital in Melbourne. And he joins me in the studio now. Welcome, Neville.
Glad to be with you, Norman.
It's a huge study.
Yes, it took a long while. It's been a lot of work, but at the end of the day, I think it's been worth it.
So let's just talk about, why do NSAIDs in theory increase the risk of a heart attack?
Well, that in itself, I think that theory is pretty muddied, but more to the point, they did appear that they do increase the risk a little bit. If I just wind back a tiny bit, the problem with the NSAIDs that I think most people know is they do cause some damage to the gut and can cause a bleeding ulcer. So when it was worked out that there was one molecule they block that's bad for the stomach, and the other one they block is good for the pain and inflammation, that's when the selective COX-2 NSAIDs were developed. And to begin with...
that's what celecoxib is.
That's right.
Then infamously there was a sister drug called rofecoxib.
Right, and you're bringing me really to what was the main source of the concern in a big study, because these drugs seemed generally pretty safe and were likely to cause less ulcers and less bleeding. Both Celebrex and rofecoxib were trialled to try to prevent bowel cancer. The irony is that both of them showed benefit in that, but after about 18 months, in two of the studies and not the third, there began to be slightly more heart attacks, and it got to the extent with rofecoxib of being about twice as much. Could have been chance, but seemed unlikely to be chance, so there was suddenly concern about the whole family of them.
And there was an element of hiding the results, and rofecoxib ended up getting taken off the market.
Some of that's true, actually, and it was perhaps almost surprising that Celebrex remained, although it did appear to have rather different properties. And what we also know now is that probably all of the NSAIDs slightly increased the risk of a heart attack, and we didn't know that because in the old days they were never tested to the same level.
So Pfizer, the drug company, funded this study to compare Celebrex against two other common ones, ibuprofen and naproxen.
Yes, I think they really were planning to look into this anyway. In fact, I know they were with a study they didn't go ahead with. But then the Food and Drug Administration in the States said, look, this is a concern, and so they mandated the study, and Pfizer then had no choice. It's been a big and expensive exercise.
And you were independent of the drug company?
We were. In fact, the steering committee, in fact, interestingly, every member of the executive committee every year signed an affidavit that they'd take no finance from any maker of any NSAID.
So what did you find?
Well, the key thing was there going to be a difference in cardiovascular deaths?
And these were people who with rheumatoid arthritis and osteoarthritis, so they were taking it for pain relief for their arthritis?
Absolutely. They needed it. So they'd proven they needed it. They'd been on it for at least 6 months. It was judged that they needed to continue with it for up to 3 or 4 years. And they were told that one of the drugs might increase their risk of a heart attack. So, that was brave people to tackle it. The primary endpoint was just that. Was there an increased risk of cardiac death, acute myocardial infarction, that is heart attack, and acute stroke? It was the first time I've been involved with what's called a non-inferiority trial, where you start from the very beginning to plan the study on the assumption that there will be a difference, and you want to find out if there is. Normally you're doing things in the reverse order. The answer, to cut to the chase, was that, perhaps almost to the surprise of some of us, there was no difference between the 3 NSAIDs in cardiac risk. There was actually a trend to slightly less on the one that's safer for the stomach. And perhaps most importantly, there was a 1/3 reduction in all-cause mortality that was statistically significant.
So was that from bowel cancer or what?
No, most of them will have been cardiovascular, renal, GI. Look, I can't actually tell you the full breakdown of the deaths.
But it could have been a few things.
Oh yes, there would have been others.
But there have been other studies which show that ibuprofen does raise the risk of heart. I mean, so in other words, what you didn't answer was, if you didn't take any NSAIDs, would you have had a lower risk of a heart attack or stroke?
That's a really good question, and to really answer it well would be a randomised trial where you put somebody on a placebo for three years who had an increased risk of heart disease and had bad joints, and no one could ever do that. So we have to fall back on epidemiologic studies, and the epidemiology suggests there's probably a slight increase with all of them. There's one study that's just under review at the moment from Quebec province where they've got wonderful data linkage that said that the increase in risk with, probably a bit unfair for me to say this because it hasn't gone through full peer review, but I've got this far to say it looked like about a 10% increase with celecoxib and a little bit more with most of the others. But, these aren't poison. This is not like smoking and lung cancer.
So what's, just cutting now, just going a few seconds left. So what's a person to do? They've got arthritis and let's say they've got high cholesterol, the doctor's told them they're at high risk of heart disease. Should they is it safe to go and buy one of these off the counter?
Well, look, I think based on what we've found, if it were me, I would be inclined to take one of them by prescription. That means your doctor's looking after you closely. I should say that all of these patients were taking an anti-ulcer drug, which adds a little expense but also made the whole thing safer. So, if they've got bad joints, they've got to do something for pain, and if they can't exercise, that's bad for the heart. I think it's important to control pain.
So just get it in balance. And the celecoxib had lower risk of stomach problems, but it wasn't so good for pain relief. That was the other thing.
Yes, maybe so. There was a slight difference against one of the other 2 drugs and not the other. So, yep, fair comment.
Neville, thank you very much for joining us.
It's been a pleasure.
Neville Yeomans, who is Director of Research at the Austin Hospital in Melbourne.